So thank you for having me. I'd love to talk about hospice. It's very dear to my heart. My first job in nursing was delivering quite a few babies in this community. I recognize someone there that I've done that with. So I feel like it's kind of come full circle with now working in hospice and helping folks leave this world. Because as Elaine said, none of us are here forever. We all know that each and every one of us is, the plan is for us to leave this world at some point. Hospice versus palliative care. I think I want to touch on hospice first, and then we can talk about palliative and kind of what the difference is. So everyone in here probably has a different thought about what hospice is and means. We see that very, very often when we go to meet our patients and their families. Sometimes it's based on experiences that people have had, and some of it's just not having the correct knowledge. Often when people hear hospice, whether it's from their physician or they've got a neighbor that's on, they think, well, they're going to pass, it's days. It's got to be bad. That's not always the case. We really like to be involved sooner than later, so we can do a lot of education, make those last days, months, sometimes even years, the very best that they can, to live a good life, live good days. The difference is that when hospice is introduced, or when a patient or family may think this is what's right for them, is that we're changing gears from treating the disease process to treating the symptoms. So it's not aggressive treatment of the disease. It's still going to be aggressive treatment because we want to be aggressive in treating those symptoms, whether that's pain, nausea, weight loss. Those are common things that we see at the end of life. Patients themselves can refer themselves to hospice. It doesn't have to be a physician. The criteria to meet for hospice care is that you have a terminal diagnosis, meaning that the physician would not be surprised if your life was to end in 6 months or thereabout. There's nothing written in stone. Often we have patients that are on for a year or two, or they get better and we graduate off, and then later you come back to hospice. Let's talk about diagnoses that kind of bring you to that. Chronic illnesses, very common. Of course, cancer. We see a lot of cancer, but chronic illnesses such as lung disease, someone that's been on oxygen for a very, very long time, their requirements are continuing to go up. They've been in the hospital multiple times, and they're just tired of that aggressive treatment. Doesn't mean that they're giving up, and it doesn't mean that the physicians or the hospice team is giving up. It's just, again, switching those gears. Instead of focusing on the lung disease, let's focus on the shortness of breath. How can we make that better? How can that person be able to do the activities that they very much want to do, but save energy in other ways? Other hospice diagnoses, cardiac, congestive heart failure, again, things that are repeatedly having to have adjustments, or finding that that person is hospitalized multiple times, going to the emergency room. When I see where someone's been in the emergency room monthly, that's kind of a big sign that maybe it's time to switch gears a little bit. Hospice can be done in people's homes. That's really what we prefer to do. We call it home hospice. Long-term care, assisted living, really any setting. And I kind of compare it to a birth plan. When new parents are expecting a new baby and they like to have that plan in place of what they would like to have happen. Having a good death is also on the other end of that. What's important to you as you're dying, or for your loved ones. It can be as simple as we often have folks ask us, can I just stay in my recliner? Do I have to be in a hospital bed? You can absolutely stay in your recliner. I've had many patients that they die in their recliner. That's what's comfortable to them. That's what they want. And that's okay. We want to try and honor that, give them as much dignity and control of the situation that we can. Other diagnoses, like I said, cancer, anything that's chronic, diabetes, kidney disease, just a lot. But often it is the patient or the family that's recognizing, hey, we need help, before the physician even kind of says, maybe this is the direction we should go. Okay, palliative. So it's kind of a gray area, but we talked about, returning to the hospital and emergency room visits. Hospice is when we kind of forego those. The in-between mode would be palliative, where maybe we're not ready to completely forego all those aggressive treatments, but we know that these symptoms aren't being well managed. And so the palliative piece is to, again, focus more on those symptoms. We're still going to focus on the disease and treat it, but let's also really get aggressive with the symptoms. Pain management, do we need more pain control? Ways to curb that shortness of breath, other than just increasing the oxygen. We often use pain medications to help with shortness of breath. Ways to conserve your energy. There are actual palliative physicians, so they focus on those symptoms and really goal planning. What's the goal? And each person is going to have a different one, or family. Put that support team together. Call in the troops, as it is, whether that's neighbors, church family, children, adult children. What's the goal for everybody? So how does hospice work at home? Comes with a team, so there would be a nurse, a physician. It can be your own private physician, but we also have a medical director. I think every agency would. Social work to help navigate just that process of what to expect. Bath aid would be involved because often people are losing their mobility. For safety aspects, it's nice to have a bath aid there, even if you can still get in the shower and do it yourself, but to have that person there for safety. We have a chaplain, music therapist, and a nutritionist or dietitian. So really looking at everything as a whole. Person doesn't have to use all of those aspects of the team, but often it is needed. What's important to that person? Like I said, is it passing in the recliner? Is it staying home? We can do everything possible to do that so that we don't have to do placement, but we can also navigate that. Everyone isn't cut out to be a full-time caregiver, and it just depends on how much support that person does have as to whether that can be managed at home and how long the illness is. So, pain management, very important. People hear all over the news now, the fentanyl crisis, all of the overdoses. That's a barrier to get through often with our families and patients because they don't want to get addicted. They hear the word fentanyl and they think what we're bringing into the home to help with pain management is the same, and it's not. It's very important to us that our patients are comfortable at the end of life. And there's different things of comfort, not just physical pain, restlessness, anxiety, the losses of things that they weren't able to do, that they're seeing each week or each month, that it's a little bit less that they're able to do. So focusing on that. Spiritual care. Our chaplain comes and often will always ask, do you have a church family? Who's that minister? Bring them into that as well, just to help with the spiritual needs that also come with facing the fact that life is going to be ending and going on to another phase very soon. Has anyone had a hospice experience with a family member? Okay, good. That's more than I kind of expected. So, was it a good experience? Yeah.
Well, when you talk about my hospice experience, I recently got out of prison, and I was a hospice volunteer for 19 years, so a lot of people.
Wonderful.
Some of them, it just depends on, I think, people's beliefs system. I found that the ones that had a belief in God, the transition was a lot more smooth. You know, they go through the now and the sepsis and all the different stuff, but it was a lot more comfortable for me to be around people that had faith as opposed to the ones who didn't. It was a deeper struggle for them and for me going through that process.
Yeah, I understand that completely. I can see the patient, I've only had a handful, but the first one as a hospice nurse that told me they were atheist. And I was just, that was kind of a lot for me to encompass and to understand. But yes, point well taken. It is much easier when the person has a relationship with God. Yes?
I haven't had family members that have done hospice, but with parishioners who have had hospice, my experience is the hospice people are very gentle. I think it's true calling. With the really good ones, it's calling. That's their sweet spot. And communicate well with kind of everybody who's involved in the process. Me as an outsider, as a pastor, the family, healthcare. There's a lot of coordination at the end of who's doing what. Hospice seems to do that really well.
Yep. That we do a lot of education and preparing for what could happen, because every death is different. And just because I've seen something 100 times doesn't mean that this 101st time it's going to happen that way. So, yes.
My mother had Alzheimer's, and when she got to the point where her nerves had deteriorated so much that she really couldn't swallow, she was hospitalized with dehydration. The family had to get together and decide whether we wanted to put in a feeding tube or not. And we all went, not only no, but hell no. Fortunately, we were all together. But it was pleasant because we were in Wichita, and the top floor of the hospital is hospice care. So all we had to do was put her on the elevator and sign some papers. But the thing that pleasantly surprised me was that they had some kind of anti-anxiety medication in a cream. And they'd come in and they'd just rub her cheek with this cream a couple times a day. And it made all the difference.
Yep. What works for one person, may look completely different for the next. So we really individualize that and empower families to recognize when something isn't working. Then I always say we have plan A through Z in our toolbox, and that's there for a reason, because what's been working at 2 o'clock on a Saturday morning may not be working. We need to go to the next thing. So. Cost. Good, thank you. So Medicare, one of the best benefits, hospice is paid at 100%, so there is no cost. As long as you meet the eligibility, continue to have decline. It doesn't have to be great decline. Like I said, we've had patients on for a year and a half, and we really like to be involved more long-term because we can teach more, educate, learn more about what is important to that person and their family to make that death a good death. Most insurances do cover hospice, so that is where there may be some type of a copay or a cost, but in my experience, it really is very small. And I really can't think of an instant where we've had a patient where an insurance didn't cover hospice. I just can't think of an example right now. So, 100%. When someone signs on to hospice, especially if it's Medicare, the regular Medicare kind of goes away and everything comes under that hospice benefit. So medications are covered then under hospice if they're related to the diagnosis. Any medical equipment that's needed, hospital beds, walker, you name it, that would be delivered to the home, or if it's long-term care or even assisted living, wherever the setting is, that would all be delivered, and then all the care that comes from the hospice team. That includes some supplies like, Depends, protein drinks. If someone did have a feeding tube, because on occasion we do have that, maybe the person's had it for a few years for something else, and now they're on hospice, we can still continue that as long as it's being helpful. at the end of life, like you mentioned with your mom and not being able to, getting dehydrated, not being able to have oral intake adequate, that's the natural process at the end of life. Just yesterday I was asked about an IV for a gentleman. Like, that actually can do more harm than good at this point. I know it makes sense because when we see our loved ones decreasing what they're taking in food-wise or fluid-wise, we surround everything, or certainly a lot, around food, meals, family time together. So it's distressing when someone has stopped eating and is losing so much weight. But it is part of the natural process. At the end of life, the body knows that it doesn't need that as it's shutting down. So it is normal we don't want to give IV fluids. We really don't want to put in a feeding tube just because a person stopped eating. We have to look a little deeper as to what the reason is for that. Yes?
It also depends on where you live. I'm from a little bitty nowhere town in the middle of nowhere, Kansas, and they have a really wonderful hospice. My cousins was part of it, but they don't have all these arms sometimes.
Mm-hmm.
Maybe you'll have to reach out somewhere else to get those arms to fill in for what's available. But the other thing is, don't be dumb and get it early. Don't wait till the last minute when it's already pretty much over. That's not that helpful.
Yes, it is helpful. Like I said, the sooner that we can be in. And we don't always have all the answers either. I typically tell families when I first meet them, I don't come with a crystal ball, and unfortunately I don't have a direct line to God. So I don't have all the answers. All I can do is take the cues that the patient is giving us each day and help support the family on how to manage those symptoms and those needs. So,
One of the things that, like my family don't understand is that hospice may be in there for 5 minutes or 10 minutes or 3 hours, the nurse, but they're always there. You're one phone call away. We have a chaplain, we have a music therapist that will even come and sing it to you in your home or over the phone. We have volunteers that come in and will sit with the family to give them a little bit of respite just for an hour, 2, 5, whatever it takes. So when my family thought about hospice, and I see it in everyone's family, is that it's death. It's not, hospice is not death, and hospice is there to help.
yep. And we often get asked, even by some of our patients, this isn't going fast enough. When are you going to bring in the medication to help me leave? That's definitely not what we do. We don't come to do that or to even help hasten the process in any way, shape, or form. And the medications, a lot of times people, I talked about being fearful of addiction or that it can cause someone to pass quickly. It really is not. We use and start with very, very low doses, and we only give it as needed for that symptom. It's not something that we just automatically, we're going to start this medication, that's what we're going to give every 3 hours. It is truly what is the need, and we are definitely not there to make anything go faster.
I have a question. When my father-in-law was dying, he was on hospice for 3 years. I mean, it worked, but I was a lot younger then, and I worked in a hospital, so when things went south, I went panic. And I called the hospital and, of course, was told, and is that still the case? The hospital was not involved at all. It was, once you put them on hospice, then that part's over, correct?
So nothing is written in stone. If somebody had cancer, they've been on hospice, and all of a sudden, hey, there's an experimental drug that may be helpful, you can take yourself off hospice with one signature, go and do aggressive treatment again. Again, it comes down to what's the goal. So as far as going back to the hospital, what would be the reason for that, and what do we hope the goal is from going to the hospital?
Mine was to alleviate the symptoms. I couldn't stand
Okay.
To me, separating, so I wanted to fix it.
Yeah.
That wasn't the thing to do. It's a process. So I just didn't realize.
It is. So, if symptoms aren't controlled at home, that's, when you call the hospice nurse and say, this is what I'm seeing, what else can we do? There are times where maybe we can't manage it at the home, and we have the hospice house available, long-term care, another setting where we wouldn't do IV fluids, but maybe we do need to do IV medications. It works a little faster and a little differently, stronger than giving oral medications that are usually liquids. So we do have the hospice house available for that as well.
So is that long-term care and hospice house also part of what Medicare pays for, or is that an additional?
The hospice house would be covered by Medicare. Long-term care, unfortunately, like Elaine touched on, that is private, unless someone would have a long-term care policy. Every once in a while, we will come across a couple that has that. I think as the generations are getting older, I don't know if they're even offered, to be honest, because they would be extremely expensive. And long-term care, it is very expensive. So, yeah.
And we have a policy. It's expensive.
Do you? Yeah, okay, I imagine they are.
Had
Yeah.
it for a long time, before my husband died, so, yeah.
Okay.
And if you're intending to do that, make sure you do that before you have extensive health issues, because then it's not possible.
Yes.
And so it's really a fine line as to when you start and how much you're going to willing to pay to do it. So,
Yeah. Yes.
If I were to have somebody come to my home and have hospice in the home, does that mean that the day-to-day caring, as in changing bedding and clothing and that kind of thing, is my responsibility? Or if in the middle of the night they need pain, do I get to give them medicine, or how much will they do in one home?
Right. So we always say we aren't moving in, unfortunately, but we are going to give you the tools to be able to do those cares, to know how to help change clothing on a person who can't get out of bed or out of the recliner. But in addition, we do have, like I said, our aide that can come 2 or 3 times a week, take something off the caregiver's plate. They can help with changing. Phone call, we are a phone call away, 24/7, and I believe every hospice agency has that capability, so that you're never alone. It may not be that they're there in the house with you, but if you have a question, you're fearful, you're just needing some reassurance, am I doing this right? They're a phone call away. What we do suggest is if someone needs more than what we can provide in the home, because again, we don't move in, there are private care duty companies or agencies that certainly aren't cheap, but it's not going to be the $11,000 a month at long-term care. And so we do encourage that at times. And this may be just even a block of time. Maybe you need 2 hours a day. So it's different than paying for a 24-hour period. Mm-hmm.
What training do these home care aides have? Are they certified nurse assistants?
They are. And then there's additional training and certification because of the fact that they're working in hospice.
does some of these extra insurance, like I have 2 insurance, so sometimes the other one pick up some of this that Medicare wouldn't, like, I don't know what. I mean, they're not going to pick up long-term health care, but would they pick up some of the in-house home nursing and stuff like that?
Usually not. Now, a long-term care policy, often it doesn't just have to be in a long-term care setting. They also will pay for some in-home care because that's just considered custodial care. Yes?
Does this vary by state?
In some ways, but not a lot, because Medicare is, a government entity. As far as, differences from a state, like I mentioned, we certainly would never hasten death or do any type of medication to cause a death, but there are states, I believe Washington, Oregon, where currently that is legal to do some type of euthanasia. That would be the big difference. Otherwise, state to state should be fairly similar.
Are there volunteer hospice people? And if so, is there training available?
We do have volunteers, and they do go through a training process. There's lots of different variations of what our volunteers do. Anything from we do a weekly phone call to all of our patients and families just to make sure that there isn't something that they need last minute. That's usually done on a Thursday. We have some volunteers that are retired nurses, so they're able to go and reinforce the education that we've already done. This is the medication for the pain, this is the medication for restlessness, and also help with some of that, as Marcia mentioned, hands-on care. If there's some extra needs that aren't being met, then we use our retired nurse volunteers or those with any type of medical experience to be able to be in the home for a few hours and help alleviate. Great questions. Like I said, I have not come across an insurance yet that doesn't cover hospice. So it may look a little different as far as a copay, but as far as the benefit, it should be very similar.
So if you're young and poor, does Medicaid cover hospice?
It does.
Wow.
It does. And most agencies, we wouldn't turn anyone away for lack of being able to pay. We just wouldn't.
I worked with a lot of kids, and I've had some kids die, and I was really surprised. I had a baby die that I worked with, and hospice was there for that family. And so I didn't realize that hospice covered children.
It does.
I was pleasantly surprised by that, because that was a huge need for this family.
Yeah. And those are even more difficult decisions to come to because you just, can only imagine for a child you would probably feel as a parent that you would never give up. But there does come that time where we just know that there is nothing else that we can do.
Kris,
So.
let them know that we have aftercare too.
Yes, Elaine talked a little bit about the grief process. That doesn't just go away overnight, and hospice doesn't go away just because the death has occurred. There's that family, friend, support group of this person, and we follow them for bereavement for over a year, and sometimes even longer if that need is there and that person needs that support. Often they'll have a good relationship with whoever is covering the bereavement for that family or the chaplain for that ongoing support. And then grief support groups. There's lots of options, new ones I hadn't even heard of that Elaine had kind of mentioned. But important to do that self-care afterwards because, like I said, grief doesn't go away just because the death occurred. And it sneaks up when you least expect it. 7, 8 months later, all of a sudden on a Wednesday, something clicks and it all comes flooding back. So that just takes time and it is a process.
I'm sorry to be asking.
You're fine. I love the questions.
You're home alone with your loved one, and it's late at night, and you're wondering, is it time? What are some of the symptoms or the things to look for that you know your loved one is actively dying, and now it's time to, really gather the children, whatever it is?
Yeah, so we do educate folks on what to watch for, and we try and tell people we think we're down to maybe the last 7 or 10 days. Maybe we followed this person for the last 6 months, and now we're seeing those signs. So much, much reduced, if not stopping, oral intake. Maybe just sips of water or a bite here and there. Sleeping a great deal more, if not the majority of the day. Increased pain is often. Restlessness, anxiety. And the person may not verbalize that this is restlessness or anxiety, but you're going to see it. They just don't know what to do with themselves. At the very, very end of life, we often see kind of how we gauge as nurses in telling the family, we think your loved one is now actively dying, is an increase in heart rate, increase in temperature, and that's often because of dehydration. So again, back to the decrease in intake, a lower blood pressure, and again, the sleeping or unresponsiveness, more confusion is very, very common in the last days or weeks of someone's life that is passing, to talk to people, family members who have passed before them. I have heard this so many times that I have come to completely believe that that is true, and I never argue or say no, that there's, no, so-and-so is not sitting there in the corner, because I do believe that's probably the case, and they're coming to take them to the next place. So.
You said that there's signs when they're actively dying. Is there kind of a standard amount of time that actively dying encompasses? Like, is it the last week, the last day? Where do you categorize it as actively?
So really, all those symptoms I just talked about help, but the biggest key marker is the intake. When someone has stopped eating and drinking, and it's not because they're nauseated, they just say, I don't want any. That's the body saying, we're shutting down. We know it's time. That's probably the biggest indicator.
Well, I would assume if they stop eating and drinking, that limits the amount of time they have left in.
Usually. You would be surprised that 2 bites, can actually sustain somebody for quite some time. So it is shocking at times. A few sips of water, but when they completely, yes. So. Excellent questions, which also, tells me everybody has a different experience and a different outlook and feeling of how that works. I always tell families it's not an emergency when this person passes, because we're expecting it. In the state of Kansas, the other benefit to being on hospice when someone dies is that we don't have to call 911, we don't have to call the coroner. The hospice team can take care of all of that because it is an expected event. Also tell them they don't have to be in a hurry. So I loved Elaine's story of staying with Jose for over an hour by herself. I tell families, if it's the middle of the night and it's a wife, you wake up and your husband, you find that he has passed, it's okay. You don't have to immediately pick up the phone. If you want 2-3 hours, that's okay. And families appreciate that. Or you need other family members to come because you want them to be there with you. Take their time, then give us a call, and we come, confirm that the person has passed, and help them with that next process.
You call a funeral home?
We do.
If somebody dies and there's nobody there, do you guys have to come and certify that they are actually dead?
We do we attend every death and confirm that has happened, yes. Yep.
I might say that I've been with 3 family members, either shortly before they died or when they died, and all 3 were different. So, it's not always the same.
Yep, you're exactly right. Each death is its own and is different.
My husband was in long-term care and under hospice, and his mind was not very good, but he really connected with the music.
Yes.
The lady came in with her guitar and sang, and it really brought something out in him that.
Yes, we see that all the time. Patients that haven't been verbal for quite some time, music will all of a sudden, they're singing along or talking. It's quite remarkable.
He was telling her about someone that he knew when he was young,
Yeah.
And she told me later that she went home and researched It was Leroy Van Dyke, actually, if you've heard of him. He was a country singer, but anyway, he was from my husband's hometown.
Okay.
And so he told her all about this man and what his songs were and everything. And so she went home and researched and then came back and played some of those songs for him. And it was very meaningful.
Yeah, music triggers memories a great deal, and can bring out some really unexpected,
It's like my Alzheimer's friend. She didn't remember her family or anything or anybody. She was, completely out of it as far as everything. But they'd start singing hymn because she played the organ all these years, and she sang hymns with them.
Yeah,
Remember the songs and words.
yeah. Anything else? Or any other information that I haven't covered yet that someone would want to know?
Just as with Alzheimer's patients, people may not respond, but they hear so often, they hear what you're saying, kind of be really careful about their dignity and respect, and don't talk behind their backs. They need for that conversation.
Yes, we always say that is the last sense to go, even though it may seem that the person is unresponsive and comatose, be another word. We completely believe that they can hear until the very last breath.
And I think some people wait when they know that a family member is coming, they'll wait. And the death comes shortly thereafter.
Yep, we have seen that.
My dad was 3.5 days in a coma and then passed. And my sister and I did not want to leave my mother alone with my dad. So we took turns in the house, staying with dad, and mom was down the hall. But one thing we didn't do well is eat, because nobody wanted to leave the house. And so we got tons and tons of food when dad first was in the hospital and stuff, and then we had nothing to eat. And I really thought to myself, if there's something that I wish I could have done, is go to Walmart and get a veggie tray and a box of crackers, because you didn't want to be gone long, but just something I could grab and eat. We weren't hungry, but just we needed something. And so, that's something I think might be something to look at maybe as part of this ministry that we're looking at or whatever, is just getting a tray that they could just eat off of that wasn't, they didn't have to order. I mean, now we can order, but that wasn't the case.
Yeah.
I mean, couldn't even think straight, and that was the other thing, your thinking process, your sleeping process, this is all new ground.
Yep.
And so one thing that we wouldn't have to worry about would have been food, and that would have been nice.
Yeah, it's a roller coaster. And yes, I frequently will ask caregivers, family, have you ate today? When was the last time you ate? When was the last time you slept? It is okay for you to go lay down for 3 hours. The volunteer will be here. You leave another family member in charge. You don't have to hold vigil, as it may be, over that person. It's very, very important to do self-care. If you can't take care of your loved one if you don't take care of yourself.
Well, the reason we did, because if we didn't, my mom would. And
Yes.
so we did that so she would go sleep.
Right.
So anyway.
Yep, divide and conquer.
That's kind of what we looked at it,
Yeah.
We have a nurse that's very, very passionate about making sure the pets, if they have pets, make sure the pets are in the room with the patient. Because the pets do bond the patient, or excuse me, I should call them patients. The loved one is bonded to that pet too. It's going to help both of them.
Yep, very important. Excellent questions. Great conversation.